Okay, everybody, this is the third part here where we're talking about delirium and dementia in preparation for the unit exam coming up. I showed you this slide that we actually had way back in week 1 or 2, and it really kind of does a nice job of differentiating the two, dementia from delirium there. Probably the key thing that you want to pull out of there is that dementia doesn't just suddenly happen on a snap. It actually is slow and gradual versus delirium, which really all of a sudden comes up really fast. It has a definite starting point that you can identify where it is. So it's important just to kind of be familiar with that, but that's what I really would like you to pull out, is that it's not something that just suddenly starts happening and you don't notice it for a while like dementia is. Well, when you look at age is a pathologic conditions risk factor that can impact cognitive function. There is some level of cognitive function decline that can occur in all people who age, but there are identifiable factors that you can point out that show more impaired cognitive functioning occurring in older adults. You will see it happen at different rates with different people. Some have very minimal, if any. Others have a significant amount of impaired cognitive functioning. However, a diagnosis of dementia still will equate to a need to preserve that person's dignity and quality of life. One of the caveats of being an RN is exactly that, making sure you're providing what your patient needs and being treated fairly, especially when they receive that life-limiting type disease. So an overview of dementia, I had shown a video that showed the process of it in the brain. I'm not able to show it on this recording because it's a copyrighted thing, but you can locate it on YouTube. But really, we know the types of things that are leading to the different types of dementias. But current research and the current focus is really on the clinical evidence of application, rather, of evidence-based recommendations to provide the care. Dementia is often misused in conjunction with Alzheimer's, when in fact Alzheimer disease is really one of 4 common types of dementia, but Alzheimer disease is probably the most prevalent one out of those 4. But by definition, it's a medical term of a group of brain disorders, organic brain diseases, some people will say, where you see a gradual decline in cognitive abilities, and then there are changes in the person's personality and their overall behavior. So some nice definitions in this slide that's actually out of your book there, which I'm going to blow up a bit here. When you look at Alzheimer's disease, it's really an insidious type of onset. You see it slowly coming on and slowly progressing. Now, your book said 5 to 10 years. More evidence more recently is saying now that it could actually be decades. But it progresses from some light forgetfulness that can be easily masked by the person, kind of joking it off, and then progresses to inabilities to make decisions and communicate their thoughts, and eventually to personality changes. It includes things like paranoia, something that's not even showing on this chart there. And it's not known at this point anyway to be reversible. Comparing that to vascular dementia, which is often referred to as the stroke dementia, it's usually related if somebody had a major stroke and it manifests in a certain area of the brain that was affected by the stroke, so that it affects sometimes their ability to ambulate, sometimes their ability to talk, sometimes their emotions are affected, and many other types of things. Lewy body dementia is another slow coming on one with a progressive decline, and it masks itself somewhat to look like Parkinson's disease. And sometimes as a result, they do get misdiagnosed that way. Now, we've got better systems for being able to analyze what's going on in the brain through scans by far than we had even 10 years ago. So it'll be interesting to see where this one progresses and where vascular dementia progresses. I forgot to mention with Alzheimer's disease that really it can't be officially diagnosed with certainty until autopsy time. And then lastly, there's frontotemporal dementia, which can be slowly but progressively creeping in early in the late 40s through the early 60s, and it takes away the person's behaviors, perhaps their motor or speech skills, and eventually leads to memory impairment. In any of the cases, not a good situation. Now, here's a couple of things to remember with dementia. Cardiovascular disease prevention and the overall promotion of good health actually helps extend cognitive function. And then the RN's responsible for doing a lot of teaching. I keep saying that over and over, I know, but we really have a lot of teaching that we do for patients about getting involved, being part of social, mental, and physical activities. It can be card playing parties. It can be some time over once or twice a week at the senior center. It can be getting out and doing some shopping. And that's where the spring up of a lot of companies that are providing caregiver assistance to help do the things. Some of them involve going to the grocery store with them and helping them do their shopping, which provides some social interaction and also the physical activity, overall promoting cognitive wellness in the process. Now, functional consequences, this is Miller's model, associated with dementia in older adults. Those functional consequences, when it comes to this area of dementia, really vary among individuals. So you really need to acknowledge that each person is different, and each person who has dementia is still there. They need to be acknowledged as such. They need to be talked with like they're talking like the next door neighbor, even though they may not be responding as readily or as logically as we come to expect people to do. They still are there. And a lot of times the personhood is concealed rather than lost. It's not that they don't have things going on upstairs anymore. It's that it's not able to be brought out. And another important facet of this is to remember that functional consequences not only affect the person who has the disease, but also their significant others, the wife or husband, the caregivers, caregiver partners, including at assisted living facilities and group homes. Family and extended family, they are affected by it. Unfortunately, sometimes maybe embarrassed by it, probably feeling guilty because they're angry about it sometimes because of the types of things that maybe come out that aren't the nicest, but certainly not are intentional. It's just that they don't have the control of the output. Now, to identify stages of dementia, it's nicknamed the FAST scale, but it's really the Global Deterioration Scale and Functional Assessment Staging, which is the GDS/FAST scale. And it utilizes 7 stages to describe functional consequences, starting at the preclinical stage and progressing to the terminal stage. And these you can look at in your book. I'm just going to scan in your notes there. I'm just going to scan them through quickly there, starting from obviously no cognitive decline and moving up from there. These 3 stages, stages 1, 2, and 3, are the pre-dementia stages. And you're going to want to remember that. And that's where you start having things to develop from nothingness, no problem, I should say, to some very light problems. Then as you advance, when you start with stage 4 and go all the way through stage 7, those are the actual dementia stages. And starting in stage 5, I'll back up to that for a second. Notice that first sentence, the patient can no longer survive without some assistance there. That's an important turning point when they reach the moderate to moderately severe level there. And sometimes these patients will cover 2 different areas. And what I'm going to do is encourage you to go to this link. It's actually on your notes, and you should be able to click it online through your links and connect there. And it will actually give you a version of that, which I encouraged you in class to consider printing off and bringing into clinical. And if you run across somebody with dementia, see what their defined level is and what it's perceived, and then apply this and see if it kind of matches up. In the early stages of people having dementia and diagnosed with it there's really some misconceptions there. A lot of people have the perception that somebody with dementia has no idea of what's happening to themselves, when in fact just the opposite is true. They have an awareness of those initial changes. While they're joking off some of that forgetfulness, they're feeling like, what is going on? I can't remember anything. If they truly had a lack of awareness, anosognosia, that's the diagnostic term, anosognosia, then there would be one issue. But they really have an awareness of what's going on. But as the disease progresses, they become less able to really compensate somehow. I've used examples of people who have joked things off with a common phrase there. And sometimes you see some real levels of anxiety and depression because they're aware that they can't get it out. They can't explain things. There's loss and fear and shame and anger and sadness and anxiety, frustration, loneliness, depression. Oh my gosh, the list could go on and on forever that occurs in these people. Creating a plethora of nursing diagnoses to come up with, depending on what you're assessing they're experiencing. And you draw conclusions from information you have, not from preconceived notions that you have in formulating those diagnoses. When you're coming up with nursing diagnoses for the patient, don't forget the needs of the caregiver or the care partner, because they're experiencing it as well with stress overload, compromised family coping. Can you imagine having somebody you're married to for 50, 60 years who suddenly is worsening to the point where they don't know you anymore? And talking sometimes not the nicest to you, and they would never dream of doing that, if they weren't having this disease process going on. Caregiver role strain. They've poured everything into taking care of them and can't anymore. And now they're having probably to take them to a memory care unit, an assisted living, or a nursing home to have people that are more skilled in providing that type of care. And there could be a grieving process that goes on as a result. There are some nursing interventions that you can do in terms of addressing dementia, providing reassurance with redirection, so that as they are trying to explain things and they can't get it out, pause and let them get it out. Acknowledge what they're saying, even if it doesn't make sense. Provide good exercise and nutrition areas, address what cares that they need, and also make sure, you're taking care of the caregivers and the care partners, whether it be at a facility or the person's spouse. There can be teaching about different medications for dementia. If the patient themselves is able to understand that, that's great. If not, include them in the conversation when you talk about it with their spouse or their family member that's overseeing their care. And then look at non-pharmacological, probably would be better than non-pharmaceutical, interventions for promoting wellness with people with dementia. Some great ones exist there with music therapy and aromatherapy, bright light therapy, which is that 40 hertz of natural white light to promote gamma brainwaves, which can sometimes really provide some soothing comfort for a patient, and actually brings out a little more stimulation for talking again, and activities really aimed at improving cognitive functioning through thinking, concentration, and memory. And let them talk. Some other interventions, just communicating with older adults with dementia. We saw that beautiful video of the granddaughter talking with her grandma, and how you approach that. So you don't ever correct, you don't ever condemn, you just talk with them and let them say their piece. And when you can acknowledge some things, or if there's something they're finding funny, you can find it funny, really makes a difference for working with people with dementia. Also look at considerations for non-Alzheimer's dementia. When it's Lewy body, or it's certainly any one of the other ones there are certain things that you need to handle differently from Alzheimer dementia. But make sure you're addressing those needs and the needs of the caregiver regardless. The whole idea is to maintain a certain level of dignity and quality of life, and keeping that person free of pain, of fear, and of the anxiety that can happen with that. even when they're